Recently, I ran on a 55-year-old male with chest pain. His presentation wasn't screaming cardiac chest pain, but rather just kind of vague, could be anything package of generalized malaise and precordial discomfort. He denied shortness of breath, nausea, and other complaints. The onset was an hour previously while watching TV. He says nothing makes it better or worse. He can't describe the feeling well. No radiation. Severity is a 5 on a 10 scale. He has a history of hypertension, takes lisinopril. He also takes a statin of some kind. The last meal was several hours ago and it was fairly normal, not anything spicy or whatnot. We already covered the events. He has a blood pressure 140/90, heart rate of 80-ish, and a respiratory rate of 18. His room air sat is 95%, and here's his EKG. Go ahead and pause it. I know you're not going to pause it, but we're going to pretend you're going to pause it. Nothing interesting there, at least nothing clearly wrong. Sometimes YouTube content doesn't give you the world's most scary EKG, huh? And this patient presentation is really common. Chest pain, but not dying immediately. Nothing obviously life-threatening. It's going to take a lot of work and diagnostics to get to a final diagnosis. It's not always something that we can accomplish necessarily in the pre-hospital setting, but we give it a try. Let's talk about how I work through a call like this. I'm Angry Bill, and this is pre-hospital wisdom. We understand that medicine's medicine, but pre-hospital providers have special skills, knowledge, and culture that other providers don't have. Let's raise the bar here a little. Do me a quick favor. Click the like button if you like this. If you really like it, tap subscribe. It helps more than you realize, and I would definitely appreciate it. When I'm on a call, I get to a point where I have a pretty good idea of what's going on. I have the OP Cure STA story, sample history, or whatever other mnemonic you happen to use. A set of vital signs are taken, and any other valuation adjuncts like 12 leads and blood sugar levels are done. After about 5 questions or so, a medic has enough of an idea of what's going on to piece together a one-sentence description of what's up with the patient. 55 male, non-specific chest pain. At this point, I need to think of differentials. Differential diagnoses answer the question, what's going on with this patient? What else could it be? So for atraumatic adult chest pain, a minimal differential list would include things like this. Acute myocardial infarction, whether STEMI or NSTEMI. Pericarditis, myocarditis, or endocarditis. The versions of angina, stable, unstable Prince metals. Pulmonary embolism, pleural effusion, pleuritis, acute aortic syndromes, that's thoracic aneurysm or dissection. Costochondritis, intercostal muscle strain, occult trauma. Don't forget this one, even on atraumatic lists. Pneumothorax, pneumonia, hyperventilation, thoracic disc herniation, coughing-related stress fractures or rib fractures related to neoplasms, arrhythmogenic pain such as from tachyarrhythmias, aortic stenosis, reflux esophagitis, GERD, malingering. This one should always be last. It's a diagnosis of exclusion. And there's many more, but this is a decent start for now. As I'm working through the call, I think of these diagnoses, consider specific presentations or information that would rule in or rule out each diagnosis, and continue to work through the call. For example, when considering PE, I would ask about the nature of the pain. Consider the patient's respiratory rate and heart rate, pulse oximetry, ask about birth control, not in this patient, but you know what I mean. Ask about immobility or travel, and so on. Eventually, I get to the point that I find PE to be unlikely and mark it off my list, or find that I can't rule it out. In the latter case, I need to treat for that condition. With this patient, as the call went on, I asked myself, what else could it be? Occult trauma came up on the list. I asked the patient if he had experienced any accidents, falls, car crashes, bar fights, shark attacks, that kind of thing. He chuckled and denied. I lifted his shirt and checked his chest and back, atraumatic. I essentially put a line through occult trauma on my mental list and asked the question again. What else could be going on? I worked my way through the list to pericarditis. Without asking the patient, I attempted to ease him back from a sitting position on my pram to a supine position. Just click the little red thing and lay him back. The patient commenced bitching about how that made him worse. I asked him about recent medical or dental procedures, and he told me about having extensive oral surgery performed about a week prior. Well, now, seems as though pericarditis is still a contender, huh? Pericarditis is still on my list. But here's the important thing. As I start treating the potential pericarditis with IV access and analgesia and so on, I ask myself the important question. What else could it be? That's the most important question. I use the patient's presentation to decide how I work through the list. If I'm caring for a patient who looks sick or toxic, like pale, cool, diaphoretic, altered, hypotensive, all those things, I would start at the most dangerous items on my list, like STEMI or NSTEMI or those kinds of things. My personal most dangerous chest pain cause list includes AMI, PE, the aortic problems, pneumothorax. If a patient looks just fine with normal vitals and an unconcerned affect, I would instead begin with the more common diagnoses like GERD or muscle strains and so on. Apparently, some medics don't practice pre-hospital medicine in this manner. They're more comfortable working off of a complaint-based list. A chest pain patient causes them to mentally turn to the chest pain checklist. Vital signs O2, 12 lead, IV access, aspirin, transport. Be ready to tell the nurse the OPQRST answers and then go to the lounge. Abdominal pain results in the abdominal pain checklist. Vitals, O2, 12 lead, IV access, transport. Altered mentation has a checklist too. Just do the tasks. In my humble opinion, this is a poor way to provide care. Continually ask yourself the most important question. What else could it be? Work through another differential on your list. What else could it be? Keep ruling out or ruling in the items on the differential diagnosis list. It's interesting, by the way, that trauma care is similar, but with a different question that changes the mental orientation towards a call. Stay tuned for the difference coming in the future, week or so. Let me know what you think of all this in the comments. If you found any value at all from this video, please click like and subscribe. One of the most helpful things you could do is share this content with someone you know. Click over here for another video, or click over here for the channel page and all videos. Subscribe's a button below. Trying to hit 1,000 subscribers, so help me out. I'm Angry Bill. This is Pre-Hospital Wisdom. Until next time, stay safe.